And it's going to use the pathogen genetic code. And the RNA on the vaccine is going to teach our body to make a type of protein that is going to be unique to the virus. Mild side effects are always expected. Pretty much with any vaccine, some people will have soreness, redness around the injection site, fever, headache, muscle aches, but these are supposed to be last maybe a couple of days, maybe one need to take Tylenol or ibuprofen, but are usually self-resolved and we can just self-manage it at home. Having said that, some patients or some people overall are very concerned about vaccines. Why should I get a vaccine? Will I get sick with the virus if I get the vaccine? And the reality is that what I said at the beginning, vaccines help us protect against diseases. So there is the numbers of hospitalizations in the United States from flu and from pneumonia, pneumococcal infection are increasing considerably. About 808,000 people have chronic hepatitis B that can cause future health problems, including liver damage, cirrhosis, cancer. And HPV, the human papillomavirus, causes 27,000 cancers in women and men each year. And about 4,000 women die each year of cervical cancer. And I think that this specifically is a success story in the United States. The rate of cervical cancer has decreased considerably since we started using or offering this vaccine to teenage girls and boys. And shingles affects about 1 million elderly people in the United States. And these patients, even after the rash is gone, they can have subsequent pain for years. And these are all preventable diseases and deaths. And I thought this chart was really good because vaccines usually will have some annoying side effects. They will have redness, swelling, pain, but the disease per se is always much more severe. Especially meningitis that causes inflammation of the membranes of the brain, sore throat, nausea, stomach pain, diarrhea, paralysis, are all really important symptoms that we can avoid with vaccines. This is the CDC vaccine schedule for adults, and what is not here is now the COVID vaccine, and really Central will talk more about this, but there's no specific contraindications for patients with TTP to get any of these vaccines. However, we know that the news are scary and there is plenty of press on what can happen to patients not only with TTP but also with ITP and other types of autoimmune disorders when they get the COVID vaccine and how it could be linked to rare blood disorders. The reality is that, as I said, local adverse reactions are common in 65% of the patients, usually self-resolved. Most commonly, patients have fatigue, headache, muscle pain, fevers and chills were less common, and anaphylaxis is very rare, 50 episodes in 10 million doses. There is a condition called vaccine-induced thrombocytopenia and thrombosis that we saw with AstraZeneca and Johnson & Johnson COVID vaccine, not so much with Pfizer and Moderna, and it occurred in 1 in 50,000 people younger than 50 years old, and 28 cases in 8.7 million doses of Johnson & Johnson. The case fatality was 23% for AstraZeneca and 10% for Johnson & Johnson. And unfortunately, sort of a clear causal relationship was really not identified. And we should not forget that there is a risk for long COVID in patients that, of course, will get it more if we're not vaccinated. And then there are these symptoms that we continue to have 12 weeks after an infection, being that it can range from being very mild to very severe. And those symptoms include extreme fatigue, shortness of breath, a brain fog, changes to taste and smell, and joint pain. And it is thought to be due to an overdrive of the immune system. It is more common in women. And unfortunately, there's no proven test or diagnosis test for treatment or diagnostic test for these. But interestingly, patients that had these symptoms, about a third of the patients that expressed symptoms of long COVID had a decrease in their symptoms after receiving the vaccine. And now moving into the role of meningococcal vaccination in a typical HOS. So patients that have a typical HOS and are receiving treatment with eculizumab or ravulizumab have a C5 blockage that is going to prevent the formation of a membrane attack complex that is part of our immune system. Specifically, MAC is required for clearance of encapsulated bacteria. And patients that are on these medications have 1,000 times increased risk of Neisseria meningitis, and that's why patients should receive 2 types of vaccines for meningitis, accompanied by antibiotic prophylaxis through the duration of the treatment with these medications.
So, I think this is probably one of the most common questions that we get from patients generally, and that is, I have a TMA or a thrombotic microangiopathy, and you always say that whenever the immune system gets revved up, or there's like a virus or something happens, I'm at risk for a relapse or recurrence of my disease. So how safe is it to do vaccines in patients like me whenever we're intentionally sort of driving that immune system? And so that's what we'll talk about here. And I really was wanting to use COVID vaccines because as these vaccines have come out and are sort of used ubiquitously, this is one of the most immunogenic vaccines that we sort of recommend to all adults, right? Compared to your normal flu shot and things like that, I'm sure many of us can even attest to sort of feeling it a little bit more than your average vaccine. And so and this is probably one of the most common vaccines that people probably have questions about. And given the reports that Camilla was just highlighting in the news, there's always concern about relapses or new disease that can occur associated with these vaccines. And so to sort of specifically answer these questions, in immune TTP, I'll present one study and then another one in complement-mediated TMA. But for patients with immune-mediated TTP, we conducted a study that looked at the Vaccine Adverse Event Reporting System, or VAERS, which is a national database that's maintained by the government. And it's where any provider can go in and submit, hey, my patient got a COVID vaccine, or any vaccine actually. We specifically looked at COVID for this study. And then they can say, what happened to my patient? I believe it's due to the vaccine. And then we also conducted, along in that same study, a review of all the patients with immune-mediated TTP that are followed at Ohio State, Johns Hopkins, as well as the University of Minnesota, who received COVID vaccines, and then what was the outcome in those patients. So here's the data that we were able to extract from the VAERS database. And this is a breakdown just of all the details of the patients that were collected, but I sort of bullet pointed some of the highlights or the things to pay attention to from everything that we collected. So out of a total of just under 190 million patients, these aren't vaccines, but these are distinct patients, only 37 cases of TTP were reported. Now, as you can imagine, this is all driven by providers who are inputting their data into the system, and so there's a variability in the amount of clinical information that we have to assess, was this actually TTP or not? And so we devised a sorting system, if you will, of definite TTP, probable TTP, and then possible. We were being a little bit polite, but the possible is essentially, we don't think that this is actually a legitimate TTP episode based on a number of clinical factors that were entered into the system. Definite are people who had a reported ADAM-TS13 activity that was severely deficient in conjunction with their episode. And then probable was all the clinical information that we had does indeed match with TTP, and so this could be a case, but we don't have an ADAM-TS13 activity. And so in all the definite and probable, 13 of them were probably not at all TTP. Using that 37 though, even giving the benefit of the doubt that the possible category was indeed TTP, the incidence after the vaccine was 0.195 per million patients. And so if you look at the incidence of TTP just sort of naturally occurring, that's about 1 to 3 patients per million. So the incidence of TTP episodes after COVID-19 vaccination is substantially less than what you would sort of naturally see occurring in the population. And then when we look at our experience at these centers where we have providers who are very well aware of TTP and see a large volume of patients, there were a total of 79 patients who were vaccinated from May of 2020 to May of 2021. And only one patient developed a relapse of their TTP after vaccination, which was attributed to vaccination. And in this patient, her ADAM-TS13 activity was undetectable prior to vaccination. She kind of long-term had undetectable activity. And she was treated successfully with caplacizumab, steroids, and rituximab. So our conclusions from this was that vaccination is safe in patients with TTP, immune-mediated TTP specifically, provided that their ADAM-TS13 activity is greater than 20% prior to vaccination. And that generally speaking, from our rough literature review around this time, most immune-mediated reactions of even the ITP or other hematologic issues arising after COVID-19 vaccination came from the adenoviral-based vaccines of AstraZeneca or Johnson & Johnson as compared to the mRNA vaccines, which Camilla described in the Pfizer and Moderna products that we have here in the US. So switching gears, looking at the COVID-19 vaccines and atypical HUS or complement-mediated TMA, there's a center in the Netherlands known as the Radboud University Medical Center. And if any of you were at the complement-mediated TMA talk earlier, that they're part of the Cure IHUS consortium over there. And so they looked at a review of all of their patients who were followed and treated at their center and who received the COVID-19 vaccine. So out of a total of 41 patients, they had 29 patients who were not receiving any therapy, and then they had 12 patients who were maintained on long-term complement inhibition therapy. And I just wanted to point out that the majority of the patients that they follow on a long-term basis are indeed kidney transplant recipients. So these patients do have some other immunosuppression on board. 88% of their cohort had known genetic mutations in the complement pathway. And 39 received mRNA vaccines and 2 received AstraZeneca. Only one patient had any signs or symptoms of TMA after vaccination. However, this was later found to be due to tacrolimus, and it did resolve when they stopped that medication. And so their conclusion was that vaccines are not likely to trigger relapses in atypical HUS, although they do have some expert recommendations noting that high-risk patients based on either their genetics or other risk factors may benefit from ongoing complement inhibition therapy if they're thinking about doing these types of vaccines as a potential trigger. So to conclude, vaccinations are safe in patients with TMA, and I always try to illustrate to my patients, we're worried about potentially worried about the vaccine causing an issue. However, this is something that's, planned. We know when you're getting it. We can also monitor you afterwards. It's going to be a lot worse getting COVID than necessarily getting the COVID vaccine. That's going to stimulate your immune system way more than just receiving the vaccine product. We always recommend to coordinate with your hematologist or nephrologist to kind of minimize any potential risks of relapse. And for immune-mediated TTP specifically, that would be just ensuring that you have an adequate ADAM-TS13 activity prior to doing any of these things. And then while any stressor on the immune system can induce the clinical syndrome, vaccines are well tolerated, they don't usually cause issues. And then depending on your individual situation, especially if there's a lot of anxiety or other issues, it's very simple to monitor on a more frequent basis afterwards if we need to. And so I think that'll do it for our talk, and then we're kind of open to questions and comments if anybody has anything. I'll sit down for this and sort of open it up.
Thank you for presenting the great presentation. So you showed us this 37 all possible, probable, likely TTP flare after the vaccination. do you have any information as to what type of vaccine that those patients get?
Yeah, it's on the table. The majority of them did get mRNA vaccines. However, the proportion of patients that received an adenoviral product that had an issue was higher. So the absolute number of mRNA was higher, but the relative proportion was lower. Yeah.
And then like the other thing that we always have to think about is like TTP, whatever TMA can occur at a natural incident. So sometimes like we don't really know like is vaccine like really a culprit, because like we don't really have like what is the time frame, right?
Yeah.
Because all this report are like maybe it's happened like 6 months later, like you may have infection or something else, or you lack of prophylaxis. I don't know, so it's kind of hard to.
Well, and that's where those categories come from too. So if it's like you said, they got a vaccine and then 6 months later they have a TTP episode and it's reported, that's probably not due to the vaccine, right?
I mean, the reporting system is not perfect, right? But also, you're right, for example, even for the AstraZeneca and the J&J vaccines, there was not sort of a causal relationship that could have been established in this syndrome of thrombocytopenia and thrombosis. Even though it's possible, but it's just really hard to assess causality.
And this is for either one of you. This is for receiving any like 1-2 doses boosters, or is it just reflecting the standard 2 dose or just 1 dose?
Yeah, at the time that study was done, I believe there was only 2 doses and maybe 1 booster that was available. Most of those patients received 2 doses unless they received just like 1 of Johnson & Johnson. Because this was done sort of in the height of the pandemic, if you will, because we collected data in 2021. So it was before the number of boosters we have now.
Yeah. And I'm sorry, I just want to say that I think pretty much every vaccine has been associated with thrombocytopenia at some point, right? MMR, influenza, varicella. I think that there's been more attention perhaps to the COVID-19 vaccine, but ITP, the drop of thrombocytopenia after a vaccine has been reported extensively.
So is this thrombocytopenia in some ways the same type of thrombocytopenia that you would see if somebody has an infection?
Yeah. Mm-hmm. Usually I will say that at least for ITP, because the ITP population have the same concern, should I get the COVID vaccine? And they looked at virus and also other reporting system, I think, and what they found was that the ITP cases, that it was true, some patients reported a drop in their platelet count with the vaccines, but it was either self-limited or every patient responded to steroids and the thrombocytopenia resolved.
Yeah, the same thing happened with viral infections.
Right.
With the viral infection, the platelets often they. I have a question. So your 37 patients, only 1 relapse. Do you have the Adams TN13 for the 36 patients?
Yeah.
Oh, so the 37 was what was reported in the VAERS database, and then 16 of those did have a reported ADAM-TS13 activity. But then in our cohort, there were 79 that were treated, and only 1 had a relapse.
Oh, this one.
And she was at OSU, and so I was treating her, and she was like a confirmed.
But the other 78, did you have an Adams TN13?
They never relapsed, but they were followed.
A good Adams TN13.
Yes. Yeah. They were all above 20% on their remission checks, and so temporally, I don't know that we actually saw that if their remission ADAM-TS13 activity was prior or post vaccination.
So, and I have so in your conclusion, you mentioned that maybe to check Adams TS13 before giving vaccination.
Yeah.
This is what you. So do you check in all your patients Adams TS13 before vaccine?
I do, but that's also partially because we told this lady to go get vaccinated and she got a relapse, and so that that availability bias is certainly there. But actually, I actually do have my patients. I mean, if they had it like just a week or 2 ago, or if I saw them in the last month, that's fine. They don't need to check it like the day of or anything like that.
Yeah.
But a recent add MTS
Yeah.
13, I do prefer that.
You also check?
Yes, and it's the same as for ITP, right? You want them not to be perhaps just coming out of a relapse before giving the vaccine.
Well, the question is, do you need to check out CFRP or do you monitor after the vaccine? That at the same time is the same.
Yeah, that's a good question.
It's a conversation.
Yeah, I think that we don't know the answer to that because the important virus is very heterogeneous, right? But I think that it depends on every patient. But if you have a patient perhaps with a recent history of TTP that you were monitoring every 3 months and she's sort of borderline low, you may want to repeat a couple of weeks after the vaccine. I think that especially now that we have very easy to get CS13 activity at home and revision, it's better to err on the side of caution perhaps than, And the other topic that we wanted to bring up that we didn't include in the slides was that some patients receive rituximab either as part of their primary diagnosis or as part of a preemptive therapy while they are otherwise asymptomatic. And rituximab has shown to decrease our immune response, that sort of the immune response that we expect after getting a vaccine. So the idea is that if you have a patient that is receiving rituximab and you're discussing vaccinations beyond really COVID-19, is maybe wait 3 months before receiving the vaccines. It's not going to hurt them, but it's not going to help them.
But what if you, I have patients who are planning to give the rituximab, how soon or how far away from needing to get the vaccine and then, and then get rituximab would you recommend?
3 months.
So like that.
Well, so I think in these situations, it depends on if there is urgency for the vaccine, and if there isn't, I would maybe do the Ritux first, then wait 3 months, and then give the vaccine. Yeah, so I might kind of flip the order there. But it depends on the situation and what you're doing. Yeah.
My understanding was like in 4 weeks you already develop the antibodies to the vaccine. And I will be honest, I don't wait 3 months, I wait like few weeks and then I give the rituximab.
Right, I think so this is the opposite. Patients that for whatever reason receive rituximab and then want to get the vaccine.
Oh, so, this is the 3 months.
Yes.
Okay.
Yeah.
So then before just 4 weeks.
So I think some of the rheumatologic providers are doing 6 months a lot for rituximab. So I would, like 3 months, 6 months, I don't know what's better.
No, I've heard 6 months too.
Yeah.
It's hard for me to say.
For some of the patients who had like lots of comorbidities, I have actually told them to go ahead and take the vaccine and then do a booster again in 6 months.
Right, the vaccine
Especially
3 months, if anything, it's not going to hurt them at all.
Yeah.
Probably they're not going to, they may or may not have a response. The reality is we don't know how long is the effect of rituximab, right? Otherwise, we would have solved many.
I mean, in other disease states, they just push forward with vaccination anyway, because if you get a benefit, that's great, and if you don't, it's not like CLL comes to mind. They know that they don't, they've done all these studies, they know that they don't mount the right response, but they're still getting every booster that comes out. And so, not that we're like inducing a similar state, but like, it's fine.
Yeah. I should put the